Our topic for today is early postpartum hemorrhage. For the definition, early postpartum hemorrhage is defined as bleeding that occurs within 24 hours, usually immediately after delivery of the placenta. The volume exceeds the normal 500 ml of the third stage blood loss. Close delivery room monitoring is crucial for 2 hours postpartum in order to rapidly identify and treat postpartum hemorrhage. Blood loss is often underestimated. The delay in the treatment can lead to coagulation disorders with a risk of massive diffuse bleeding. For the management during the first 30 minutes, ask for help as resuscitation measures and obstructive management must be performed in parallel. Record in the chart the results of the initial evaluation, monitoring in actions, and indicating the times. So the management consists of resuscitation and initial obstetric management. Nurses are then expected to be familiarized with this management. Now for the resuscitation, lay the patient flat and monitor the blood pressure, the heart rate, consciousness, respiratory rate, and the oxygen saturation. The objectives is that the systolic PP should be more than 90 millimeter mercury and more than 95% oxygen saturation, with a normal level of consciousness and with urine output of more than 30 ml per hour. So if the systolic BP is less than 90 millimeter mercury, which is hypotensive, we elevate the legs. Keep or replace the patient's feet in the delivery table stirrups. Then insert two IV lines, either in catheter gauge 16 or 18. Then we give fluid replacement with Ringer's lactate or 0.9 sodium chloride or plain NSS. Then we add 1 gram of tranexamic acid. So tranexamic acid inhibits fibrinolysis by displacing plasminogen from fibrin, thus decreases bleeding. Then we give oxygen. We can give as much as 15 liters per minute. Then we determine the patient's blood type and select potential donors or make sure that blood is available. And we measure the hemoglobin level as a baseline data. Then, we give the initial obstetric management in parallel with the resuscitation efforts. So we evaluate and monitor the blood loss. We remove the placenta manually if it is not yet delivered, either by the physician or the nurse midwife. Then perform uterine massage to expel any clots and aid uterine contraction, to be repeated every 15 minutes for the first 2 hours after postpartum hemorrhage. Then insert a Foley catheter because keeping the bladder empty facilitates uterine retraction. Then perform uterine exploration to remove any blood clots or placental fragments and check for absence of uterine rupture. Then we can give oxytocin. So oxytocin is a uterine stimulant which results in uterine contractions. We can give 5 to 10 units by slow IV, or we can give it with Ringer's lactate or plain NSS over 2 hours. Then inspect the birth canal, check for the injury to the cervix or vagina using retractors. If bleeding persists 15 minutes after giving oxytocin, and only if uterine atony is suspected, administer misoprostol. So misoprostol is a synthetic prostaglandin E analog which would stimulate uterine contractions. Or we can give metal-ergometrin, or the brand name Metergine. So it produces vasoconstriction to increase strength, duration, and frequency of uterine contractions. Now for the management of persistent hemorrhage after the first 30 minutes are the following. It also consists of resuscitation and further obstetric management. So first, with resuscitation, we continue the fluid replacement. We administer the second dose of tranexamic acid, and we administer blood transfusion in patients with massive hemorrhage more than 1,500 ml, with hemodynamic instability, such as hypotension, those with coagulation disorders, and if the patient has hemoglobin of less than 7. We can give fresh whole blood or packed red blood cells or whole blood plus fresh frozen plasma in the event of massive hemorrhage and/or coagulation disorders. Parallel to that is the obstetric management. So in the event of persistent atony, we can insert an intrauterine balloon. And if the bleeding continues, we can perform the following, such as stepwise ligation of the uterine blood supply, uterine suture, and we can do radical surgical treatment such as hysterectomy with agnestal preservation or subtotal hysterectomy. Now, for the management of immediate massive hemorrhage, so in the event of 150 ml of blood loss per minute of shock, we can perform initial management as quickly as possible and do not wait 30 minutes to perform further obstetric management. We can give transfusion as quickly as possible. And if necessary, we can perform one of the additional compression measures in the next slides. The first maneuver is the aortic compression. We can apply pressure to the abdominal aorta just above the umbilicus until the femoral pulse is no longer palpable. Or we can do bimanual uterine compression. It can be done by uterine compression between the fingers in the vagina and a hand on the abdomen, or we can do uterine compression between the fist and a hand on the abdomen. So that's it for the early postpartum hemorrhage. Thank you for listening.